We are live now. You can start.
Yeah. So, good evening, everyone. So, it's a very important webinar, second webinar on anaphylaxis. And yesterday, our excellent presentation. I think very useful for practicing pediatricians and allergy specialists. And today, chairperson, our senior most allergist, sir, our guru, T. Sukumaran sir, moderator by Dr. Salini. And of course, today, first talk by food-induced anaphylaxis by Soumya. And second, drug-induced anaphylaxis by Dr. Taha Ashraf. And third, venous hypersensitivity by Narmada. And fourth is about labs support. What lab to be done to confirm know it is anaphylaxis or not? It's very important talk by Dr. Murlisa by USA. And skin prick test and drug interprocan test. When to be is a very important part of the objective evidence. This is Indrani Haldar. So this is so I request our chairperson Neeraj Gupta to say a few words.
Dr. Shalini, I think you can directly moderate. Thank you.
Yeah.
Sure.
Okay, sir.
Thank you. Welcome everyone to the second phase of Anaphylaxis Decoded. And we learned the basis of diagnosis and treatment yesterday from eminent faculties. Today we move on to the second part, and the topics are already being described by Dr. Reddy. Today's chair is Dr. Sukumaran. I'd request him to declare the session open, please.
Okay. Beloved Dr. Shalini, Chairperson Dr. Neeraj Gupta, Secretary Dr. Ubin Narayana Reddy, other speakers of the day, Dr. Soumya, and Dr. Murali, and other dignitaries on the platform, and my dear friends. It gives me great pleasure and privilege to be here, to be with you, to participate in the second webinar on anaphylaxis. I should congratulate the executive board members, especially our chairperson Neeraj Gupta, then Secretary Narayana Reddy, Ubin Narayana Reddy, and our chairperson Dr. Danesh, and all the executive board members for organizing such a wonderful program every day. I think I should congratulate once again Dr. Neeraj for his exemplary work that he's doing for the chapter. Lot of activities is done by him. And today, our webinar is mainly on anaphylaxis decoded, the second issue, beyond basics, trigger and testing in anaphylaxis. Anaphylaxis is a common problem in children. I think the anaphylaxis diagnosis is not very difficult, but the treatment is a real problem. As a practicing pediatrician, what I have seen that even though the drug of choice is adrenaline, people are resistant to give adrenaline. Recently, one of my assistants went to a beauty parlor, and they had put some paints in her face, and she developed anaphylaxis. She was taken to a hospital, and that my assistant told that I am having anaphylaxis. You give me adrenaline. But the hospital people were not very keen to give adrenaline. Then he was shifted to our hospital. We gave adrenaline and everything was fine. And there is some problem. They will start Dexona, there is no problem. He's starting an antihistamines also, they are very happy. But they are not very happy with adrenaline. And also, EpiPen is not easily available here. I think our beloved friend and our charter chairperson, Dr. Paramesh, has done some works to prepare an indigenous EpiPen. I think it is on the way. It will come soon. And with these words, I request Dr. Neeraj to start the webinar. Thank you. And I wish this webinar all the best. Thank you.
Thank you, sir. So with those words, reiterating that anaphylaxis is being underdiagnosed, undertreated, and the scientific approach is still lacking. So we move on to the second webinar. The first talk is by none other than the famous allergist from Bangalore, Dr. Soumya, and we know that she speaks very well and very crisp. I request all the speakers to stick to time so that we have some time left in the end to take some questions and to discuss about it. So over to you, Dr. Soumya. Your 20 minutes start now.
Thank you. Thank you, Dr. Shalini, for a very kind introduction. And I hope my slides are...
yes, they're visible. You could put them in the slideshow. Yeah.
Yes. Thank
Perfect.
you.
Yeah.
Thank you. At the utmost, I would like to express my gratitude to Dr. Neeraj and the entire EB team of the IAP Allergy Immunology chapter for taking this very relevant issue, as Sir was telling, which is very underdiagnosed. And I think it's the need of the hour. So, I think before we dwell into the background of food, we had excellent sessions about the basics of allergy yesterday. Just a couple of slides regarding the historical background. I think mainly anaphylaxis is very well described in literature. And I think first was described by Portier and Richard in the early part of the last century. I think mainly they were trying to immunize the dogs to the venom of a sea anemone, where they unknowingly sensitized the dogs, and these animals had reacted to a previous non-lethal dose. So they termed they put the term as anaphylaxis, meaning without or against protection. So we all know that anaphylaxis is a very serious allergic reaction, which is very rapid in onset and can progressively deteriorate and can be fatal as well. Basically, I think the anaphylaxis, as highlighted by the speaker yesterday, Dr. Vikram, where the allergen exposure anaphylaxis can be likely. There are 3 scenarios, and which has been updated in the recent WHO guidelines as well. So mainly, I think in the first scenario, it could be the skin or the mucosa with the involvement of the respiratory or the cardiovascular system involvement. In the second scenario, it could be the skin or the cardiovascular or the respiratory symptoms along with or without the GI symptoms. And the third scenario could be the just presentation of hypotension alone. So I think if we feel that anaphylaxis is being occurring in a patient, I think we shouldn't be hesitating to treat it. So initially, I think where we were thinking that anaphylaxis is not very common, in the 1990s, where the epidemiological studies were showing about incidence of about 3.2 cases per 1,000 inhabitants versus around less than 1% for anaphylaxis, we have seen an increase of anaphylaxis in the recent past. So this was a long-term follow-up of patients over 10 years, where they have found that the rate of anaphylaxis has increased by over 100%. And here the main increase is seen in the children, and the rate of food-related anaphylaxis has increased beyond the incidence of anaphylaxis by over 124%. And the medication also related anaphylaxis is over 200%. So I think it was just the lack of awareness or probably the sensitization of peers to pick up anaphylaxis and accordingly treat. I think over the last few years, decades, I think anaphylaxis has been being sensitized more, and I think the incidence also is more because of more awareness, though more work needs to be done. So I think infants, teenagers, pregnant women, we all know this, these are fall under very friable population. But also severe anaphylaxis has been reported with older age group, also with comorbid conditions, cardiovascular diseases underlying, and asthma. I think in the context of food allergies, the risk for asthma patients who are not being well controlled and having food-related anaphylaxis is several-fold higher. They say it's at least 30% better. More of these patients having the risk of anaphylaxis due to food trigger. So whenever we have patients with food allergy and if it is associated with underlying asthma, it is important that for us to get the asthma symptoms under good control to minimize the risk of severe allergic reactions in these patients. Also, as Sukumaran sir was highlighting earlier, delayed epinephrine administration to patients with anaphylaxis previously, or because they could also have a risk of biphasic reaction, where the symptoms can recur after few hours. So this is a main factor in our country, I feel. Also, symptom denial. Though in the recent past, I think thanks to the efforts of the chapter, the food allergy awareness is better. But there are also some times where when a patient tells says when they are in social setting or in a restaurant that the patient has food allergy, and the patient needs to be taken care that there is no cross contamination. Symptom denial, or also some other peers denying that the patient has food allergy, history of previous severe reaction, they are all at high risk for anaphylaxis. And sometimes, if the patient only presents with hypotension with the lack of cutaneous symptoms, where we feel that if the absence of hives or other cutaneous manifestations is not there, we do not consider that patient as having anaphylaxis. So I think it's important that we should try to keep this risk factors under consideration. As we all know, I think in the children under 5 years of age, I think some of the pictures are missing. Sorry for that. The children, in under children, I think top 9 food allergens are being described across the world. Though we have some regional and cultural variations in India, but I think the top 9 food allergens include milk, egg, peanuts, tree nuts, including cashew, almond, pista, um, seed allergies, wheat, soy allergies, fish, and sesame, which has been the latest entry in the last few years to the top 9 food allergens. Whereas in adults, the chances of the persistence of milk and egg allergy are less, as most of the children tend to outgrow. Though the recent, we have been traditionally talking about 70 to 80% of the children tend to outgrow milk and egg allergies by about 5 to 6 years of age. In the recent 1 year, I think there has been epidemiological data which has come out, which puts that the outgrowing of milk and egg allergy could be close to only about 60% at age 5 to 6 years of age. Though that needs validation in subsequent publications. The adults mainly tend to have allergies for peanut, tree nuts, fish, and shellfish, and seeds. Though any food can be allergen, but 90% of the food allergies are usually from this list. And in India, we may have other regional variations such as chickpea or some lentils, but that is a very minor proportion as compared to this top 9 food allergens. In children, I think when we talk about anaphylaxis, food is definitely the most common trigger in infants and young children. And milk, I would keep that the first. Sorry, I've put the peanut. So generally, milk is the most commonest trigger in our Indian scenario, followed by egg and peanut. And adolescent, mainly, I think we encounter frequent reactions to tree nuts and shellfish. So the triggers of anaphylaxis, when it comes to the physical triggers, it could be exercise induced. Also, when it comes in conjunction with a food or a medication, which are often cofactors, these could be the triggers at the increased risk of anaphylaxis in these patients, where the food themselves they are able to tolerate, or they have no limitation of the exercise where they could do, or they tolerate also the medication. But when they come in conjunction, they act as cofactors for increasing the propensity for anaphylaxis. So what are the factors which are related to what we call as cofactors for anaphylaxis when it comes to food? So mainly it could be age-related, concomitant diseases, or concomitant medications which are taken in conjunction with the food. But the cofactors generally we define as factors which can amplify whether the patient can tolerate or have a milder allergic disease, or probably anaphylaxis as well when they come together. So I think more of the cofactors include exercise, when the patient is having an acute infection, the patient has frequent travel, lack of sleep, hormonal changes, emotional stress. So I think these act as cofactors which can amplify the severity or the occurrence of anaphylaxis. So mainly, I think in the background of food allergy, mainly we have where the food per se, when they are ingested, the antigen presenting cells take up this food in the intact form. If they are stimulated by the T cells to produce B cells, we can have an IgE mediated reaction. Or if it is T cell mediated, mainly the pathophysiology is in the background of non-IgE mediated presentation. So coming to one of the entities, food dependent exercise induced anaphylaxis, where exercise is one of the cofactors which can, in the background of the particular food ingestion, can cause anaphylaxis. And we have had excellent talks in the past by Dr. Neeraj also regarding the same. So in this background, anaphylaxis is triggered by specific food ingestion, followed by exercise very soon after the ingestion of that particular food. So basically, when the patient has a particular food, by itself, where the patient tolerates these foods without any having problems of any food, symptoms of food allergy, immediate or delayed reactions, but the patient has a vigorous physical activity within 2 to 4 hours after that food ingestion, these can amplify the risk of anaphylaxis. But they can be good athletes, they could have good threshold of exercise, but when they come in conjunction, they can cause having symptoms, and it is definitely under-recognized in pediatrics. So basically, the pathophysiology of food-dependent exercise-induced anaphylaxis, these exercising, there is increased vascular permeability, and the threshold for the tolerance of the causative food is decreased, and the severity of the reaction of a possibility of a severe allergic reaction is more. And especially this is amplified in the presence of cofactors such as NSAIDs or alcohol consumption, where there is decreased gastric acid production, and the chances of the absorption of structurally intact food allergens is more because of the increased gastrointestinal permeability. And this leads to the cross-linking of the specific IgE on the high affinity epsilon receptor IgE receptors, leading on to the degranulation and releasing of the chemicals which causes this anaphylaxis. The food triggers which has been well described in children include wheat, especially omega-5 gliadin, shellfish, milk, nuts, especially in the background of peanuts, and soy, though we see some variations in geographically or culturally. But I think by far wheat far outweighs the other foods, because that is more well described. Onset, it could be within few minutes to 2 hours post-ingestion and exercise, and it could read on to the range of anaphylaxis reactions as described earlier with the multi-system involvement. So I think in the background of food induced anaphylaxis, I think though history is very important, and it is very difficult sometimes, detective work finding like a needle in a haystack. I think whatever history is taken, I think based on the good clinical history, our testing has to be directed, be it skin prick test or serum specific IgE. I think it has to be based on the patient history. And once we have done a demonstration of the sensitization to that particular food IgE, we have to corroborate with the second history again. So if it is just positive on the sensitization, we should always go back to the history, because if the patient is already tolerating and we get the positivity, it does not mean anything to us, and we may consider challenge under medical supervision if required to demonstrate. And as we all know, the serum specific IgE testing must be done at least 4 to 6 weeks after the index episode of anaphylaxis in food because of the massive usage of the mast cells. So if we do testing earlier, we may actually get false negative results. So this was a review article which was published about 3 to 4 years back, which is well documented, where they showed that the cutoffs for the serum specific IgE by immunocap and skin prick test with a positive predictive value, where it shows the beyond which, if we do an oral challenge, we would get a positive. That means the patient would react if we do a oral challenge beyond these levels. So this acts as a good reckoner, but always has to be dealt in the context of clinical relation. Also, we also have a proposed diagnostic cutoff values for the component testing, which may help us in clinically deciding how to proceed with this patient. So diagnosis of food-dependent exercise-induced anaphylaxis is generally cumbersome and is only limited to research settings, where they say that you have to exclude aspirin hypersensitivity on one day, followed by exercise challenge, and rule out food allergies, and then only come in conjunction to make sure to confirm food-dependent exercise-induced anaphylaxis. But most of the times it is clinical in nature. So when we are talking about FDEIA, always make sure that we have history corroborating that the patient can tolerate those food and exercise independently without in conjunction, and we have a differential diagnosis to be considered along with food hypersensitivity, rule out other causes of presentation such as exercise-induced anaphylaxis or mastocytosis, among others. A word of note in the FDIA management, because it is important that we encourage something called buddy system, where the patient, if he is going for any physical activity, somebody is with him, or he has the emergency medications, and always to make sure the help is promptly given if the patient has this FDA EIA. So the conventional teaching versus food allergy and in exercise-induced anaphylaxis is that if the patient has the background of hypertension or cardiovascular disease, convey the need to take beta blockers and angiotensin in the AC inhibitors with caution, because they increase the propensity of anaphylaxis, and there is no rule of biologicals or oral immunotherapy in the background of food-dependent exercise-induced anaphylaxis. This is one of the anaphylaxis action plan I commonly use, can be downloaded by the foodallergy.org, very freely downloadable. And this gives a ready reckoner for the patients or the caregivers alike when to suspect anaphylaxis and when, and adrenaline administration must be given, and it can be given to patient to carry it around and also improve the awareness among caregivers. So I think we had excellent talks about the treatment of anaphylaxis. I think I just want to emphasize that we shouldn't be denying epinephrine if we are thinking anaphylaxis, and we wouldn't do any harm by giving anaphylaxis. I think just last couple of slides before I close my session. I think it's important that when the patient has had anaphylaxis with food allergies, it becomes extremely important for us to educate the patient and the family, because most of the reactions occur outside of home. And it has been documented that at least 20% of these reactions occur in schools or in colleges and also in restaurants. So I think it's important to sensitize. I think even in our cities, there has been gradual awareness, and we had an food allergy community care program which was launched just last month. I think we had our stakeholders from the restaurants also who joined us, and they're open to actually thinking about giving allergen-free food for our patients as well. So I think a lot of work needs to be done, but I think we are in the right direction. It's also important that patients who have had anaphylaxis in the context of food allergies, it's important that they have these social issues where they have anxiety, they're referred for, they have bullying. So it's important that we address as well as that. So I think we need to create awareness when we have food induced anaphylaxis. And it is not just identifying the allergen alone, give them emergency action plan, what to be avoided, food labeling, also educate the caregivers, and also take the social aspect into consideration. So thank you. Thank you for a very patient hearing, and thank you for the opportunity.
Thank you, Dr. Soumya. You took exactly 20 minutes for that. Now, there's a question in the chat box. Is it possible to have normal SPT or specific IgE to wheat in case of wheat-dependent exercise-induced anaphylaxis?
Yes, it could be. Yeah. So I think that is where component testing is of help. And I think Sir would be highlighting in his talk, because I think, as we said, these patients would not be having necessarily allergy to that particular food, which they would be tolerating even in the absence of this cofactors or other triggers. So it is possible we could have normal SPT or serum specific IgE.
Perfect. A point from my side, with the latest knowledge of anaphylaxis, we know that only hypotension can be a presentation of anaphylaxis in absence of skin symptoms. And we are now much aware of food-dependent exercise-induced anaphylaxis. So combining both these things, we can now, I think, diagnose much more anaphylaxis than that we were doing before. We've had news of, a bride falling on floor while dancing in a dance party could have been a food induced anaphylaxis, which we didn't know. So even for doctors, if we are aware of this situation, we'll pick them better. And by virtue of webinars like this and by help of Dr. Neeraj Gupta, we're spreading the awareness well. Now, if there is no other question, thank you, Dr. Soumya. You can stop sharing the screen. And now I invite Dr. Taha Ashraf Qureshi from Srinagar to take a very, very important topic of drug-induced anaphylaxis. I think what more is required at the same time is to delabel the not so proper drug allergy. So over to you, Dr. Taha.
Thank you so much, Dr. Shalini. I hope I'm audible and my screen is visible too.
Yes, sir. You can go on a slideshow mode.
Yeah. Yeah. A very good evening to everybody out there, and thank you so much, Neeraj sir, IIP Allergy Chapter, giving me this opportunity to present this topic. To just my humble attempt to present this topic in front of you. I hope I'll be able to do some justice with the topic. Drug-induced anaphylaxis. Its diagnosis and safer alternatives. This is something what we'll be talking about. Well, the definition-wise, drug-induced anaphylaxis is just like any other anaphylaxis, but of course, involvement of some drug, maybe minutes before, or usually maximum an hour before giving the drug. Nowadays, the definition goes even before 6 hours, but typical definition says up to 1 hour or so. Involvement of mast cells, basophils, typical type 1 hypersensitivity reaction, IgE mediated most of the times, but the story doesn't end here. Well, we can have a non-IgE mediated anaphylaxis as well. That's what we call anaphylactoid reaction. It mimics true anaphylaxis, and the mechanisms, be it whatever, but ultimately the patient presentation is same as that of the typical anaphylaxis, because that's what matters ultimately for the clinicians. So coming to mechanisms, there's a mast cell, direct stimulation of mast cells, or complement activation in these cases. And in fact, drug allergy, a good majority of drug allergy patients is because of anaphylactoid reactions. Clinical features, I am in front of an audience who know it much better than I know. Skin involvement and angioedema, respiratory distress, hypertension, GI symptoms, cardiovascular collapse, and neurological symptoms as well. And we know you deal with it so well. Coming to the drugs causing anaphylaxis, this good work done by Tano LK, this is something, it was a multi-center study. They ultimately came to a conclusion in this study that antibiotics top the list with penicillin, cephalosporins, beta-lactams, at the top, and then other drugs as well. Next come NSAIDs in the setting of the over-the-counter drugs, then radiocontrast media as far as the diagnostics go, then neuromuscular blockers in the anesthetics in the operative settings, then biologicals and PPIs. This is the world scenario. Then coming to, this is actually the global perspective, which says ultimately that the fatalities are rising worldwide. Therefore, improvised and improved awareness and preventive strategies are the need of the hour. And coming to India, we don't have a national registry. Hospital-based data suggests rising incidence. This work was good work was done by Patel TK, and this Patel TK in 2018 did some good work. And this chart you can see over it, though the sample size is not that very impressive, is a systematic this review he did. And what you can see, I will just try to show my cursor, which is here. You can see, this the antimicrobials again topping the list, then NSAIDs, then the neuromuscular blockers, almost in line with the other data of the world, that multi-center study, the global scenario. Then individual drugs, diclofenac maximum, then etracurium and beta-lactams. So our data, our humble effort from Kashmir, we from at two different hospitals, SKIMS and JLNM Hospital, we had around 4950 cases since 2017. We delabeled 900 cases out of them, and obviously, then those where desensitization was required was around 52 cases, and we desensitized them. And minus these cases out of the 4950, 3998 patients we gave safer alternatives, did not need to do challenges really. We tried to, we in fact gave them those drugs where they were had less chances to react, and they tolerated them well. So apart from delabeling, providing a safer alternative is another choice. Then coming to the evaluation and management of drug-induced anaphylaxis, or for that matter, any other drug-induced allergy, the step one would be focus on history. A meticulous and detailed history is the cornerstone that helps us in diagnosing drug allergies. So, the key is that we have to, see the temporal association, then what the symptoms were, and then the overall timeline of whatever happened and what drug was given and what was not given. Then this is a long questionnaire actually, what we focus on, and the crux of that is, these four, these not just 3 points, 3 points on this slide. First dose versus later reactions, then what was the duration of the reaction, what was the severity of the reaction, did the patient need an ER visit, and how long the patient remained admitted hospital, does the symptom suggest that it was an IgE mediated or it was a non-IgE mediated reaction, immediate, delayed. Then if the patient had severe reaction, was it like Steven Johnson or TEN or vasculitis? In that case, obviously we don't test anymore. We just avoid the drug and that's it. Then ER visit I talked about. Then did the patient do plasma tryptase levels? What did they show, if at all they did it, and what was the overall recovery status of the patient? And again, history, where offending agent we talk about, and what was the drug, what was the route, what was the dose, and any previous exposure, what were the reactions previous, and then of course good knowledge about the cross reactivity of the drug, because many drugs can have good cross-reactivity with each other, and some cross-reactivities are real and some are, in fact, most of the believed cross-reactivities are not for real. We'll come to that a little while later. And perioperative agents, perioperative events rather, regarding perioperative operative agents, that is something where chronology has a great role. And this history really, really makes a great sense. And, then what? This diagnostic workup, doesn't stop with the history itself. Physical examination gives some clue as well. Then targeted labs, which we'll be talking about a little while later. And skin testing is a very, very good tool, especially in the case of the IgE-mediated reactions. Non-IgE-mediated reactions, skin testing has no role at all. The percutaneous testing or the skin prick testing. One of the photographs. This was done for the local anesthesia drugs. And intradermal testing on the lower side, you can see this is done for intradermal testing, and that helps quite a lot if skin testing does not help much. If in skin prick testing doesn't help much, or if skin prick testing is negative, the next step would be intradermal testing, which is on the lower right side. And finally, a graded drug challenge, and if the conditions permit, if the scenario overall is indicative of this graded drug challenge, wherein we give these drugs in 2 to 3 steps, depending on the overall risk stratification scenario of the patient, overall need of whatever is to be done. Then we talked about the lab, good lab workup, which includes the serum tryptase, already talked about yesterday. Even Dr. Somia talked about it. Fluorescent enzyme immunoassay, or the that immunocap as they call it. Very little role. Only a few drugs antigens are available, so therefore not much. Then BAT offers a good promise for future, as yet not commercially available, but definitely it offers a good promise. Non-invasive it is. That's why. Then lymphocyte transformation test for DDT allergies, again not commercially available, but yeah, a good tool for future. We already talked about skin prick, intradermal, and oral challenge. It's just not the oral challenge. It depends on what kind of route drug is to be given. For example, there are some agents which have only IV route, some have only IM route, or subcutaneous. In that case, the challenge happens through that route only. So and ultimately, what is the outcome of these challenges, graded drug challenges? If the graded drug challenge comes out to be negative, the drug is obviously safe to be used. The patient is delabeled from whatever the label was. But the delabeling is done for a drug where the risk stratification, after doing history and examination, you find risk stratification is low or medium. But if the risk stratification is high, or the reaction has been very, very severe, in that case, we don't do any challenges. We avoid the drug and find out a different class. If graded drug challenge comes out to be positive, we use an alternative class of drug. And that's where an overall knowledge and experience comes into play. There are, in general, it's not the hard and fast rule, but in general, there are some classes of drugs which are generally tolerated well. And when the drugs are not very well tolerated, even we talked about earlier about also about different studies, global and Indian as well. There are some group of drugs where sometimes if they are not tolerated very well, and among them, beta-lactams top the list among antibiotics. Then vancomycin comes around, sulfonamides, clindamycin, and among anticonvulsants, the aromatic anticonvulsants are those which are which if not tolerated generally, they top the list. Then among the tolerated drugs, most of the times among antibiotics, macrolides, even quinolones, doxycycline, linezolid, they are usually allergy friendly. Usually people don't react with them. But then anything is possible. Nothing is hard and fast. This is a general rule. This we have written, and only after having experience of around 5,000 patients presenting to us, and we seeing what they react to. But exceptions are always there to prove the rule, and I will have one case among them as well. These are some charts which actually we use to see different cross-reactivities between different groups. Like this is for cephalosporins and this penicillin group of drugs. There are cross-reactivities, which drug can be used, which drug can have cross-reactivities. If somebody is allergic to amoxicillin, which to give, which not to give. These charts should be part of our this office library. In fact, we should hang one chart over there like this. Then for NSAIDs, one chart like this. There are different subclasses of NSAIDs, though this is not the ultimate chart. There are other charts for NSAIDs where which determines cross-reactivities of these drugs, but that description is beyond the scope of present lecture. And coming to a few case presentations, I want to present this case first. We had a 22-year-old male who was a new recruit in police department with a grade 3 varicose veins. He was planned for surgery. He had developed anaphylaxis twice with preoperative antibiotic dose, first with amoxiclav, and then with the ceftriaxone. Till this time, we were not into the loop. He was admitted with the CVG's department, who called us after this. And when we took a history, there was a history suggestive of some urticaria rashes, no systemic features, following intake of some antibiotics for gastroenteritis in the past as well. Now we thought what to do. Obviously, patient surgery was a must. Life was at stake. His job was at stake. He was new recruit in police department and needed to stand for long hours in his job. We discussed the case again with the operating surgeons. The use of perioperative antibiotic from a different class we suggested, and the surgeons gave a go-ahead green signal to it. Levofloxacin we selected, quinolone, different family antibiotic as a substitute, as a potential safer alternative. We did a graded challenge to levofloxacin, and skin started with the skin testing, though some may not agree with skin testing of quinolones, but then at least it rules out IgE mediated reactions. Later on, we did oral challenge as well in 3 to 4 steps, and patient tolerated the drug well and was operated under its cover successfully. So, in fact, this was our first case when we did in 2017, and it got published as in the World Journal of Pharmaceutical Research as well. Then we had this 23-year-old male. This was just 3 years back. He was an athlete with presented history of anaphylaxis after receiving local anesthesia for dental extraction. He had received actually lignocaine, and he for this reaction needed an emergency room visit, and a dental extraction, which was supposed to be done in him, which was badly needed, that remained pending. And that's why the patient was referred to us by the dental surgeon for a solution as to how to go about his dental procedure. What we did a dental procedure with bupivacaine. Actually, these local anesthetics are two classes. One is the one is the amide class, another is the ester class. Amide classes have bupivacaine, lignocaine, then the ropivacaine. They are easily available in India. The ester class, unfortunately, is not. So after lignocaine, the next choice would be bupivacaine. Unfortunately, not many patients reactive to lidocaine react to bupivacaine. And then the other thing with these anesthetic agents is that they contain preservatives. They contain antioxidants also for the maintenance, of good action of these local anesthesia. And sometimes the reaction could be even because of that. So what we use a bupivacaine solution without a preservative to test the patient. And they are available commercially. That's not a big deal getting them from the market. SPT was negative. Intradermal test was negative. We followed the recommended concentrations. Then subcutaneous graded challenge with 0.1 ml, 0.3 and 0.1 ml, and finally 1 ml. That was negative. And of course, this is what told us that the patient would not react to bupivacaine without preservative. The patient was clear for its use. He went for a dental procedure. The whole procedure was uneventful, thankfully. Then, what happens? 2 years later, this patient comes back to us with another complaint now. He was lined up for hair transplant. Actually, the cosmetologist sent him to us this time. The surgeon used bupivacaine that time because the patient told him that I'm allergic to bupivacaine. But that time, unexpectedly, patient got anaphylaxis because of the same drug, what we had given a clean sheet to and what he had tolerated well 2 years back. So what were we dealing with? The patient obviously was referred to us. We took a detailed history again. We checked the bupivacaine brand used. Obviously, we were curious to know what happened. That brand contained methylparaben, which is the preservative and which is one of the commonest agent that causes anaphylaxis reaction. Then he had lost our prescription actually, and that's why the operating surgeon had got misled. We used the bupivacaine without preservative again. The challenge was taken obviously after 6 weeks. We gave some time to for the histamine to get replenished in the mast cells. The result was negative. We sent the patient back to use bupivacaine without a preservative, and the transplant was done successfully. So our final case, this case is a case which is very close to my heart. I often present this case, and maybe many of you would have already seen this case. It's like it's a very sensational case, I would say, just like that Alfred Hitchcock movie where there's a lot of a lot of curiosity over there as to what really happened, what was the culprit. 22-year-old female came to us, admitted with colorectal surgery department at our hospital from 3 days as a case of rectal prolapse. She was planned for surgery 2 days, after 2 days. Then her baseline investigations were normal, and her history was like on day one, she had a generalized rash after receiving IV levofloxacin. Then she had no systemic symptoms that time. On day two, this girl had anaphylaxis twice. First, after within 5 minutes after starting IV dextrose normal saline, and next episode 10 minutes after starting IV ringer lactate. Her past history, actually, this was a time when we were called to the ward, and we took the whole history there only at this stage. So she had features of perineal allergic rhinitis and intermittent asthma, which obviously, like most of the cases, was ignored. And she had no history of drug allergy in the past. She would tolerate well most of the commonly used antibiotics, NSAIDs, PPIs, even local anesthetics. She would tolerate very, very well. Now, we need to find out the culprit drug because this patient needed a solution. We thought, is it IV levofloxacin? Why should it be? She tolerates all the antibiotics in the past. Is it IV DNS or ringer lactate? Why should they be? So, these are fluids which are compatible with our body. Now, obviously, we had to play Sherlock Holmes over here, keep our mind open. We reviewed the history. At admission in the emergency room, there was one more episode. After the review of the history, she revealed this. There was one more episode of anaphylaxis, when she was admitted. And when just her physical examination was carried out, and that physical examination included a rectal examination as well. Well, was this a punchline we were looking for? The consensus was we deferred the surgery for 4 weeks for histamine stores to get replenished. We did a skin prick test for these and the challenge test as well for these antibiotics because they were to be used around the surgery time. Levofloxacin, metrazole, they were negative. This was usual, but we did something very, very unusual. We did the SPT for latex, which was positive. Specific IgO for latex, thankfully, had come to India that time. That again was positive. So therefore, our suspicion about the antibiotics and other agents was wrong, or IV fluids was wrong. It was actually the latex which was used, the gloves which were used, that was causing anaphylaxis in this patient. The cat was ultimately out of the bag. We were looking here and there. So therefore, we recommended a latex-free operating and post-operative facility in this room, with a pre-medication regimen as well. Maybe some of you might not agree with this. There are two schools of thought to it, whether doing it or not doing it. And this anti-allergic medication cover till wound recovery was, recommended by us. The surgery was carried out successfully. Patient did well, discharged on day 10. We explained the do's and don'ts to the patient about latex allergy and work up for an allergy immunotherapy for latex. We were planning, we could not do it though. And in fact, this also got published in one of the leading journals of allergy and therapy. So, conclusion, if one must say, early recognition and prompt management are critical in case of any anaphylaxis, for that matter, but drug-induced anaphylaxis, comes, on the top, especially in hospital settings. A detailed clinical history is a cornerstone of diagnosis, and graded drug challenges and skin testing, even some part of in vitro testing also are valuable tools to do it. We need to work together on this. All of us, all the specialties would need to work together on this, and we need to inculcate more and more knowledge about this into us, at least the basic knowledge. And the final word would be that safer alternatives do exist, but personalized choices matter.
Thank you, Dr. Taha. That was actually informative and so much of information in 20 minutes. But I think we'll need to get back to you multiple times because the confusion and the details still remain. I'll take
Right.
1 or 2 questions that are there in the talk. Is
Okay.
it possible to have IgE-mediated drug allergies? And if yes, what are the examples?
Well, IgE-mediated drug allergies, lot of drug allergies are IgE.
IgG.
IgG-mediated drug allergies. Well, IgG drug allergies, I have not heard about it much, and it does not look like to be, possible that we have IgG-mediated drug allergies. We have Dr. Murli over here. Maybe he can join us on this. But
Yes,
to me, by
yes.
my this knowledge, whatever immunological knowledge I have, I don't
We will
see.
ask Dr. Murali when
Yes, yes, please.
after his talk.
Yes, yes.
And can delayed allergic reaction to intradermal tests suggest non-IgE mediated reactions?
Absolutely, that's something I'm glad they asked it, and I am sure that there is some knowledge of about this already with the person who asked it. Delayed intradermal testing has now become quite fashionable, and in fact, it's a very good tool to diagnose type 4 drug allergies, not the type 1 allergies. Type 4, it is a very good tool. Fixed drug eruptions, contact dermatitis, wherever type 4 allergies exist, this has some good tool. 24 to 48 hours, actually, we wait after giving an intradermal. Obviously the non-irritating concentration of that particular drug, wait for 24 to 48 hours. See if the induration is extended more than 5 mm, or if the erythema has extended more than 9 mm. In that case, this is a good evidence to suggest that this is a delayed reaction. This is a type 4 mediated drug allergy of whatever the drug we test for. Obviously, not every drug will have a recommended non-irritating concentration. This will be applicable to only those drugs where recommended non-irritating concentration charts are available.
Thank you so much. And with that, I'll thank you for the session. And for the next session on venom allergy, there cannot be a better person than Dr. Narmada to tell us about the same. I invite Dr. Narmada from the land of Chennai. And over to you, Dr. Narmada. Your 20 minutes are on.
Thank you, Dr. Shalini, for the kind words. And I'm extremely privileged to present before Dr. Murali sir, whom I have met in a couple of times and I've listened to his talk. And it's my pleasure and privilege to present to him. So I understand the value of the time. And so I have just made a small, 20 minutes, 20 questions on venom hypersensitivity. So I hope you can see my screen, because there is so much to discuss. And Dr. Neeraj had given me the particular issue on to concentrate on insect venom immunotherapy also. So the first question itself starts with, do we need this discussion in the Indian scenario? Because we have more data on the West, but we do not have data in India. So for that, we need to understand what is venom hypersensitivity. Here we are talking about an insect venom allergy where the immune system is abnormally reacting to proteins, and this can lead on to mild local symptoms like swelling and itching to severe, potentially life-threatening systemic reaction, especially the anaphylaxis. And this is the anaphylaxis week, and that is why we are discussing about that. So having said that, we know that anaphylaxis is very occurring to the rate of 0.05 to 2% worldwide. And India, there has been very sparing report, and one case of anaphylactic shock has shown that it is occurring at a rate of 1.5 to 7.9 per 1 lakh persons. And among that, we do not know how much percentage is insect bite, though we have a comparable data in the West which says that 1 in 200 people have suffered from severe allergic reaction. Though the number is very heavy in the West and our anaphylactic reaction is comparing to 1 lakh population, maybe it is less, but still we do not have any documented proof of insect venom hypersensitivity in India. We had about we have a lot of studies that looked into urticaria or the types of reaction to insect venom. But this is the particular study done by our own Saibal Mitra group, which had looked into IgE sensitization and had found out that they have used skin prick test in children, in patients who have come with insect venom, and found out that we really had a high degree of sensitization, especially to black ant and fire ant. A similar study was done in Himachal Pradesh, which looked into non-IgE mediated. So we are looking at an immunological reaction, and we do have, except for these two studies, we are not having any studies, but these two studies itself shows there is a good amount of sensitization and there is a good amount of clinical reaction also. So we need to look into the chapter in detail. Now, what is the commonest causes of insect stings that is causing hypersensitivity? most of though there are a lot of insects worldwide, including South America have reported different insects, Europe has reported a different insects. Most of them fall into the order of Hymenoptera, and especially they belong to the genus Apis and Vespidus and Polistus, which is the ant. And India, especially, we are having a lot of studies, case reports on bee venoms as well as on the wasp venom, as you saw in the earlier studies. Why we need to know this particular classification is there is a good amount of cross reactivity between the same family. So if you have been bitten by a bumblebee, you may develop a severe anaphylaxis to the honeybee also. And because the wasps are very aggressive, you may develop cross reactivity within the Vespa group and the Hornets group also. As well as we have multiple case reports, especially from Kerala, with regard to the Formicidae group. Now, what about this reaction which we are seeing in the clinic? So this is nothing but a papular urticaria that exists in the children, and it cannot be, it is of course a hypersensitivity reaction, but it is a localized and it is restricted to IgE mediated to salivary apiraces of the insect, of the mosquito group, and it does not cause any systemic reaction. So as a pediatrician or a general practitioner or as an allergy specialist, this form of an reaction to an insect venom does not cause severe anaphylaxis. So having said that, you have a reaction which comes generalized like this. Should I be bothered about this reaction? Yes, maybe, because it could be an urticaria. If it is combined with any of the symptoms involving an angioedema or a chest constriction or a gastrointestinal symptom, it can go on to grade through. If it is going on to involving the respiratory symptom, multiple other systems, it can go on to grade 3. And if it is leading on to a complete collapse, it is grade 4. This is the Muller and Ring and Mesmer classification, almost similar here. So however, if the IgE mediated is restricted only to the cutaneous reaction, or it is restricted only to the particular area, we may call it as a mild local reaction. Large local reactions are those that are defined which is more than 10 centimeter and in a child which is crossing more than 2 joints. We call it as a large local reaction. And anaphylaxis is what that comes into this place. So when we have an urticaria, we have to definitely monitor whether we have other symptoms which are involving the other respiratory, gastrointestinal, neurological or cardiovascular. So what are the chances that an LLR or a systemic reaction can lead on to an anaphylaxis next time? And this time the patient has presented to you with a SIM, where it differs when it comes to a case of an adult and that of the children. And if you know, in an adult, when they had a history of anaphylaxis, there is a very high probability that this patient will go on to have a very severe anaphylaxis next time. And so that is why we start them on an immunotherapy as soon as they have a severe reaction, which means generalized urticaria plus involving other symptoms. They had only cutaneous manifestation, we may wait and have a detailed history. However, if there is a high risk factors, which we will see in the later slides, we may start even in that condition when they had an isolated urticaria. Coming to the large local reaction, the incidence of them leading on to an anaphylaxis is very less than in the child compared to that of the adult. And again, a large local reaction in the presence of any of the risk factor, we will go ahead and do the immunotherapy. So the chances are weighed with regard to the age, with regard to the severity of the reaction, with regard to the patient's status, their hobbies, and where do they come from. Having said that, what are the characteristics of insect venom, and why should I know as a general allergy specialist or as a general practitioner? We have to understand that these are generally belonging to the group of phospholipases, hyaluronidase, and acid phosphatases, and there are specific allergens linked to that, which is for honeybee, it is M1, M2, M3, M4, and M6. This Vespid groups have West V1, V2, V5. And knowledge about this is very important in our understanding, because in the component resolved diagnostic, when you are confused about whether it is a double sensitization or a cross-reactivity, a knowledge of the insect venom character, the specific protein is only going to tell you but what type of a reaction is this. Though they are saying that it is a phospholipases, the same molecule is involved in all the forms of the insect venom. The combination with the protein, glycoproteins, 10 to 50 or the amino acid is unique for each of these insects, and that makes the allergen also very unique. So, for example, in the bee sting, you have about the marker allergen is M1, M3, M4, and the medium lethal dose is about 140, 150 micrograms, which can trigger an anaphylaxis. And this determines the dose which we have to give while giving the maintenance dosage. And medium lethal dose, when they have a mass envenomation, can be up to 2.8 to 3.5 milligram. The Vespid is also having the same phospholipases and antigen 5, but their marker protein is different in Pol D1 and Pol D5. And allergen is unique in that it's got an alkaloid protein, and the alkaloid part causes a sterile pustule, and the protein part is also more about the acid phosphatases, which is Sol-I 1, 2, 3, and 4. So what do we use this knowledge for? We use this knowledge to differentiate between a cross-reactivity and a double sensitization. So what is the cross-reactive carbohydrate determinant, which is the fructose residue on the N-glycan core that is produced by insects and plants? It is not found on human proteins, and hence a significant proportion of patients who are bitten by the insects could develop a cross-reactivity to this, and there is no clinical relevance here, but they can cause a rise in systemic serum IgE, which can lead to a confusion when we do the skin prick test. Potentially a CRD will help us at this stage, and when we do a CRD, we clearly know if the marker allergens is going to come as positive, we know that it is a true hypersensitivity. And when we are going to get cross-reactive allergen positive, it may be due to a double cross-reactive allergens, or if you're going to get the marker allergen specific for 2 insects, we know it is a double sensitization. So this will determine to us what type of an immunotherapy we are going to give to the patient. So the question is it necessary to investigate all the cases that comes with the reaction? No, we are going to investigate only when we have an adult with severe systemic reaction, and in children in a very rare case when they have multiple reaction, and they may be considered in those who had an LLR with or an urticarial symptoms with the high risk features, and these are the patients who are a candidate for venom immunotherapy. Now, the question about whether children have to be investigated in the condition where they have developed a severe LLR or an anaphylactic reaction, there are very few guidelines which recommend that, and there are a lot of case reports with regarding to children being started on immunotherapy. And Dr. Sitesh Roy also shared a case when he had started an immunotherapy on a very small child, but it is very, very rare, only because the chances of systemic reaction with the child experiencing an LLR is only 2 to 6%, and children go on to develop only systemic reaction in only 0.3% of the cases. So this determines on a shared medical decision when you know the quality of life. So what are the high-risk factors I have been alluding upon since the first slide? So here, what is the time interval between the number of stings? Suppose you have a person who's doing a bee venom, honey as his occupation. He is more prone to get stung by the bee stings. I recently observed a patient who was on immunotherapy, and even in between, he was in the maintenance dose, and even in between the maintenance dose, he had another bee sting. So in that case, you have to be really proactive and give them immunotherapy. If the specific IgE level are more than 1 kilo units, then there is a severe previous reaction. As I said, age is a determining factor. And one more condition is an elevated serum tryptase and mastocytosis. We have talked enough about the serum tryptase. I will come to it, what it has a value when it comes to insect venom hypersensitivity. In this condition, I have a serum specific IgE, I have a tryptase, I have a skin testing. What is the best test to do? We all know skin testing is the gold standard. However, the guidelines are slightly changing when there is a serum-specific IgE to be done, and there is more utility with regard to the component resolved diagnostics. And recently, when I visited Tirumala Krishna's Center on Allergy and Immunology in Birmingham, they have almost stopped doing skin testing and they have done doing only serum-specific IgE, and if necessary, a component resolved diagnostic when there is a diagnostic dilemma to find out the marker allergen. Serum tryptase value I will discuss later. So skin testing, we know it is the first line of investigation, and this is done in potentially a patient adult who is 16 years who had underwent a severe systemic reaction. As in drug allergy, we also start with the skin prick test and then we go on to intradermal. Why? We all know the intradermal test is a very suggestive test, but it is very, it can pick up the positivity greater than skin prick test, but it has got a high degree of systemic reaction. That is why we prefer to do the skin prick test. And in that also, we start with a higher concentration and work up to the higher 100 microgram per liter. If 1 microgram per liter is going to give you the reaction, we don't need to perform the other test also. However, we finish off all the concentration in the skin prick test. If they are going to be positive, you stop at that and there is a good temporal relationship. But if not, we go ahead with doing the intradermal testing. And we all know the serum specific IgE is also done. But what we need to be very careful is we go ahead with the, generation 4 or very specific IgE, which has got greater correlation when compared to the radioallergen sorbent. We do not do the panel. We ask for specific insects which we are noting based on the history. And I have already told to you about the CRD, which gives a very clear picture after your serum specific IgE has come about the marker allergen. This we do when we have a doubt of any double sensitization or a CCD. And we all know when we are doing CRD, the carbohydrate determinants will not show positive. So having said that, what is the role of serum tryptase here? Here it really matters, not only to confirm anaphylaxis. When you have the serum tryptase elevated, in a case of insect venom hypersensitivity, we have to do a paired sample where we are looking at their baseline tryptase, and if it is more than 11.4, these are the patients who belong to the category of systemic mastocytosis, and that in that condition, we need to do a genetic analysis to look for mutation, and your management of an immunotherapy and the decision to continue the immunotherapy will become different when you have a systemic mastocytosis. Having said that, the question asked is, do we need to do a test separate for WASP and Hornet? We all know that there are recombinant allergens available, but all over the world, what is usually, there's a good cross-reactivity of 50% between the Vespids and the Hornets. Some centers do follow the habit of doing for the bees separately, Vespids separately, and Hornets separately, and then coming to ants. And CRD will give you the complete picture. Whereas in London, they follow only the honeybees and the Vespids. We need to develop our own data on how to investigate a case of an insect venom hypersensitivity using CRD. Now, having decided that whom do I start or how do I start venom immunotherapy, as already said, for all those patients in adult who had had even a single amount of systemic anaphylaxis, efficacy is close to about 95 to 97%. And the slide clearly tells that when there is a risk profile, you have a sting history, and as I told you, the serum basal tryptase is elevated. You can find out the genetic mutation, either a KIT mutation or a hereditary alpha tryptasemia, and you have a CRD which clearly proves, you will definitely go ahead with giving the immunotherapy. And the venom immunotherapy, the duration is also determined by all of this risk factor as well as the basic factors like age and sex. Are there different schedules? Yes. You may go for a conventional schedule where you go the updosing phase of about 12 weeks, or you go for a cluster schedule where you go for a schedule of 7 weeks. Ultra rush and the other rush therapies are used only in very specific situation. What is mostly followed is the updosing phase of the cluster, where the maintenance dosage can be worked up within 7 to 8 weeks, and the rest the updosing phase will be reduced to 7 weeks, but the maintenance weeks remains the same of giving a gap of about 6 to 7 weeks over a 2 to 3 year period or lifelong, depending on what is your whether you have systemic mastocytosis or you are exposed to any sort of due to your occupation or due to your hobbies, you are exposed to insect venom. When you have a systemic mastocytosis, or do you have you have time and you want to go slow, you can go for the conventional therapy here. And is it safe, or can be any complication? Yes. There are biomarkers that predict the adverse reaction, and that is where the basophil activation test is coming up. and there you use an fluorescent, you can find out whether the activation of CD63, you have the flow cytometry that beautifully picks up, and there are centers who have the flow cytometry also. And when it is more than 8 nanogram, it predicts a severe skin reaction. And when you have a genetic mutation, definitely you should expect an adverse reaction. Can I use venom immunotherapy in children? This we already discussed. Only 42% of the allergists who were practicing felt comfortable, and we do not have any number of studies. Yes, the future, they may become a recommendation if you're going to have a CRD positive and the child has had a severe reaction. The penultimate question is, as a practitioner, do I need to treat urticaria with venom immunotherapy or follow them? No, definite no. Isolated urticaria does not warrant. You see it in case of other reactions also. The last question, how much of the above can I practice in India? So this is a question we all need to think about, with number of people using the serum tryptases, using a methodical way, and we have number of companies that are coming out with the CRDs. I think we should be practicing, we should be investigating any case of an insect that have a clinical correlation of insect venom hypersensitivity. I'm very sure the experts on the dais will be able to tell more about the practice in India. So thank you so much for your patient listening. I hope I have completed on time.
You definitely did, and you gave us a lot of information in 20 minutes, and you made it very clear that allergies with venom is very different from the aero allergies that we've been practicing, and a scientific knowledge and protocol-based treatment needs to be, there before you start correcting
It's
them.
actually a 1 hour or 2 hours topic, and I wanted to consume it in 20
Yes.
minutes. So I just took only the critical questions to answer.
Yes, we'll need to hear you again, Dr. Narmada. There's a question for you. Why do patients get anaphylaxis with a bee sting on the apparently first sting of their life? They have not been sensitized with previous stings. Why does this happen?
So you see, it depends upon all your factors, how severe you react. So even a first sting may cause a severe reaction, or what has happened in the previous, we don't know. There might be a bit of cross reactivity also with the bumblebee, which you should have forgotten. And if you had a genetic potential like systemic mastocytosis, those are the patients we have not investigated in India. So we do not know the genetic profile of our patients. So if the genetic profile is talking towards a more of systemic mastocytosis, we are more prone to develop the same complication. So all that has to got into the practice.
Just one thing, can I come in? Narmada ma'am, I must have seen these bee venom anaphylaxis, at least 20 to 25 of them, and none had mastocytosis. Almost none had been bitten in the past. I mean, is it something like de novo?
Give a more idea about it, and I think every one of us, we respond differently to the reactions. So it depends on our the sensitization pattern, how we respond to even a single reaction.
Can I make one comment?
Yes, sir.
I think, Narmada, you did an excellent job.
Thank you,
A
sir.
complicated subject within 20 minutes, you did it very well. But just want to let the audience know that there are insects that we don't know that are in India that can cause anaphylaxis. So we are only talking about Hymenoptera based upon all the Western type of stinging insects, but there are many insects in Asia, and especially fire ant is a major issue in India. And there could be several type of insects and ants that we need to explore. So an entomological study or a partnership with an entomologist and an allergist is very essential here. So otherwise we are going to miss, because I have had cases where the patient says definitely it was an insect, sir, but all the tests are completely negative. So we can't say, well, the test is not right, but there could be some other insect that could do it.
Because I also
Thank
heard
you.
Any in a deep south in Tamil Nadu, they were alluding upon a different thing. South America does not have this vespids. I mean, does not. They have studies which is telling about another insect which is not vespids or polystyrene. So we need a more entomological study.
Good.
Maybe I'm trying to answer Dr. Qureshi's question as to why you get anaphylaxis on the very first sting. We always think it's antigen, IgE, mast cell basophil activation, but now we know there are other receptors on the mast cell which can be activated. One is MRGPRX2, for example, and melatonin, a particular antigen seen in honeybee, can directly activate mast cells independent of the Fc epsilon IgE receptor. So those 20 cases could be people who have melatonin sensitivity activating their mast cells causing anaphylaxis.
So
So
I was
there's more.
thinking
Yeah.
MGR receptor is only for drugs, sir. It is even for
Uh,
insect.
Yes, now they're finding that there are other molecules which can bind to the receptor. Initially, it started as vancomycin related, but now other molecules like melatonin can bind.
Yeah. So thank you, sir. It was a
Thank
new
you.
knowledge. I knew about
So,
some potential, but I didn't
yes,
know about this receptor and insect.
yeah, and it's interesting because you still have to do a skin test. If the skin test is negative or in vitro test, only then you can by exclusion suggest that and study. Sorry.
Thank you, Dr. Murli. Please stay with us. You need to answer a lot of questions because the allergens are vast and the pathways that they act are so many. So we really need you to answer the questions how to go about testing them. Before you start, let me tell our audience here, Dr. Murli has come all the way from Harvard. He's kindly agreed to, educate us regarding the testing phenomena. He's an immunologist, has a professor at the Massachusetts University, and I welcome you here, and I thank you so much for being here. And there are questions from the previous talks as well, which you will have to answer once your deliberation is over.
I'm looking forward to all of this, and thank you. Can you see my screen?
Yes, I can. Yeah, you can go ahead.
Let me just minimize the one second. All right. At the outset, I want to thank Niraj for a wonderful organization. He's put together great speakers, great topics in a nutshell in 2 hours, and I think only Niraj can do that. And I'm also happy Dr. Sukumaran was there to get this started, and the PK has joined us. So I'm going to keep it in 15 minutes and talk about laboratory support in anaphylaxis. I think it's a very good title. It doesn't say laboratory diagnosis. It only says it can support it. Yeah. So anytime we go to any medical disorder, we always get a very good history, and it's all the more important in allergy than anywhere else. And after that, we examine the patient, come to a differential diagnosis, and then we say we need some laboratory test, which could be radiology oriented, it could be blood test, it could be a digital imaging, it doesn't matter. And then, based on the diagnosis and the differential, we sort it out and reach a diagnosis and then plan therapy. And after we treat, depending on the clinical course, we go back to laboratory test as parameters if the patient has improved. But this paradigm will not hold good with anaphylaxis because we get a very good history, we get a good examination, we rapidly think about differential diagnosis, but we have to treat promptly with epinephrine, which has been alluded to. So there's no time to send blood to the lab. You can't do a skin test at that time. You can't do a specific IG at that time. And tryptase takes some time. So you can't really wait for diagnosis. You got to treat. So I would say that from anaphylaxis, we get a good history and exam. We come to differential diagnosis. We realize it's not septic shock. We realize there's not hemorrhagic shock. And then we quickly treat the anaphylaxis and reach a diagnosis. And then in between comes the lab support. So I like the title of lab support as a tool. So when you talk about allergic disease, we always talk about eosinophilia, total IgE, but they have absolutely no role for anaphylaxis, so I won't even touch it. There are only 4 important things, and of these, only one confirms anaphylaxis. The others support the etiology of the causation. We'll talk about specific IgE testing in vitro. Venoms have been alluded to, but I also bring about the concept of alpha-gal, because that's another entity which causes delayed anaphylaxis, and many a time people call it idiopathic, but you need a good history. I'm not sure if alpha-gal exists in India, because I'm not sure we have the lone Texas tick there, but other insects can probably contribute to it. So PK's concept that we need to understand the entomology and insect behavior in the Asian continent is very important. We'll talk a little bit about component result diagnostics, though Narmada has really brought it out beautifully to the forefront. We'll talk a little more about tryptase and then basophil activation test. So if one looks at the timeline of allergic disease, every 100 years is what it took to find an improvement. But starting from 1967, when IgE was discovered and IgE receptors, and then later in 1980s, when allergens were identified, purified, and now we have them cloned, we can get purified components or epitopes of individual discrete pieces of allergen, be it a food allergen, a plant, or a protein. So all this has led initially to in vivo testing. In fact, in vivo testing as provocative test was done even before IgE was discovered in England and later caught up in the rest of the world. Then once IgE was discovered, there's various types of in vitro testing done, and we will talk about the best one right now. Once the antigens were cloned and their epitopes were identified and they can be synthesized, purified, we have components of antigens, and they have actually opened up the horizon of more precise diagnosis in allergy. I never fail to say why skin tests are so important. Skin test is an in vivo method to diagnose anaphylaxis, and I think Dr. Qureshi beautifully talked about concentrations, when to do it. All I want to say is, if skin test to me is the best parameter of a cross section of allergic response, because it measures how the antigen binds to its specific IgE, activates the mast cell receptors, activates the tyrosine kinases, causes mast cell degranulation, release a variety of mediators which act on target tissue to cause a positive wheal and a flare reaction. So it's almost like the stress test which a cardiologist does, because he's not interested in your static EKG or your cough. He wants to see how you respond to a stress, what are the hemodynamic changes with coronary vascular abnormalities. Similarly, the skin test is beautiful. In vitro test only measures specific IgE, and they give you a number, but they don't tell you the biology of that number, which is why we have to have a clinical correlation. And both skin test and in vitro test detect sensitization, but coupled to history, it becomes clinically important. So I want you to look at skin test as a very valuable tool, but it's got its limitations. You can't do it when there are blocking drugs and it takes 6 weeks to recover. And this is where if you have serum, you can do that. One great advantage of in vitro testing is you can use individual components to dissect the response. But wait, the Europeans have now got components which can be used for skin testing. So again, by using components of antigens like peanuts, you may be able to skin test and you may not need the in vitro test. So there is a continuous progress in both directions. IgE assays are important in the laboratory, and what they measure is the interaction between an allergen and its specific antibody, and we're only interested in IgE, not IgG antibodies, because IgGs are more blocking antibodies. And what is very important is, as PK and others have told repeatedly, a positive skin test and a positive in vitro test tell you there is sensitization. But you got to correlate to the history to raise it to the level of clinical importance. And I think we no longer use radioloid labels, so the term RAS should not be used. We use a variety of ELISAs, enzyme-linked immunosorbent assays, or fluorescent labels. To make the long story short, what is a specific IgE test in the lab? You have a plastic dish in which the green is the antigen or the peptide or the components, either could be there. They're bonded onto it. You add the patient serum. If there's IgE, the red molecule binds there, and then you probe it with an anti-IgE with a fluorescent label or with an enzyme, and then you develop the color, and the greater the color, greater the concentration of specific IgE. So that's called the solid phase assays, and that is the best. Again, I think Narmada talked about CCDs, which is cross-reacting carbohydrate determinants. It is a problem with food allergy, and it is a problem with venom allergy testing, but not so much with aeroallergens, because aeroallergens are not so much glycosylated. But if you take a food allergen in the middle panel, those little green things are carbohydrates. And the patient makes antibody not only to the peptide or the antigen, like ragweed antigen E or the Arachis H2A, but they can also make antibody to the sugar. And so the IgE binds to that, and when you develop it, you get a big answer, and you're not sure whether it's the carbohydrate reactive cross determinants or it's IgE. In the lab, in the past, what they do is they have what's called a carbohydrate blocker. They have a glycan, they mix it with the serum, it absorbs all the carbohydrate-specific antibodies, so you can unleash the specific IgE and determine it. We don't do this anymore because it's time-consuming. However, the purification of antigens, they get rid of the glycans. And when you do component, this is not a problem. So looking at immunoassays, they are direct proportional to the concentration, and they're expressed as kilo units of allergen per liter for allergen-specific IgE. They're looking at total IgE, it's kilo international units per liter. We are only talking today about antigen-specific IgE. The important thing is skin test is variable in its sensitivity and specificity. It's a gold standard. But you can tweak specific IgEs as they're doing with component result diagnostics, so the sensitivity and specificity can be high. Also, in the interpretation of in vitro lab data, one has to be careful. If the total IgE is high, you also need to look at the specific IgE in the context of total IgE, and there are various ways to calculate it. So the specific IgE is more important, not the total IgE. And if the total IgE is high, the specific IgE will also be high, but it's a ratio. The closer it approaches 1 is ideal. More than 50% is required for a clinical corroboration. Again, when you look at specific IgE, there are two important assays. One is called ISAC. ISAC is immunosorbent allergen chip on the right side. The other is the so-called immunocap, which is a proprietary name because they have like a cap-like structure, which is made of cellulose activated particle. It's like a beehive. You can put a lot of antigens. So you can load your substrate with a lot of antigens. Here, you can't load it as much. The reason this is very important is serum in a patient, say with food allergy, they not only make IgE to peanuts, they also make IgG. Our IgG is 1,000 milligrams per deciliter, whereas IgE is 10 nanograms per deciliter. So if IgE can outrun IgE and occupy the antigen sites, but if you have something like immunocap, the interference by IgG is minimized, whereas with ISAC, it is not. So much so, T.K. Krishnan and others will tell you, in England, they are not really interested in ISAC. They're only interested in the derivatives of the immunocap, and it's also better quantifiable. So there is a thing called IgG interference. That means IgG antibody competes with IgE. Since we got a lot of IgGs, they may outstrip the IgE, so you can get a false negative. But the immunocap, they have overcome that. So you start with specific IgE that gives a signal. But then you really need to ask, what is the epitope? Because not all epitopes are the same. And for this, what they have done is they have cloned the antigens, they have fractionated the distinct components, and I'm going to show you an example of a peanut as the best one for component result diagnostics. To understand the concept, imagine a child who has got allergic symptoms, and symptoms are occurring to a variety of stuff, pollens, sometimes to fruits, sometimes to vegetables. So the allergist is not sure what is causing the symptoms. The reason is the plant kingdom, the vegetable kingdom, the fruit kingdom, and the pollens all have evolved in evolution, and they have certain common antigens. Those are like the profilins. And for example, if you look at tree pollen, it has a red epitope. Peanut has the same, and tomato has the same. So, but in addition to that, tree is specific. It has its green component, peanut, the purple, and the yellow for, say, the tomato. So when you look at specific IgE, it'll bind anything that you throw, the serum. So these are common determinants causing cross-reactivity. So that epitope is not the one that's causing the specific disease. For peanut, what you really need is to pick up the purple antigen. That is the one which can bind the specific IgE and activate the mast cells to cause anaphylaxis. Whereas the profilins will bind to IgE, may cause non-specific reactions, may cause a little itching, or they may synergize, but they don't cause explosive mast cell degranulation. So the advantage of component is you can query and identify that piece of the antigen, which is the troublemaker. So let's look at peanut as an example. So what we have is recombinant. So they're all called R for recombinant because they have to be purified if you really want a good component result. Arachis hypogea is the botanical name, and 2 is the antigenic component. So when you say ARA-H2, well, there are a number of ARA-H's. You have, for example, ARA-H1, which is a storage protein, which is a 2S albumin, highly immunogenic. Then you have ARA2, which is another epitope in peanut, which is also a storage protein. Then you have ARA3 and ARA6. So 1, 2, 3, 6 are all storage proteins. They're different epitopes, but they all have the great ability to bind to IgE and activate the mast cell. But when it comes to ARA5, it's a profilin. It cross-reacts with grass. ARA8 is a pathogenous-related 10 protein, which cross-reacts with trees. So you can see how the child who was sniffing to trees and fruits is probably reacting to the profilins, the PR10s, or it could be a fruit, which is a non-specific lipid transfer proteins. These 8, 5, and 9 can cause allergy, but not to the potency of causing anaphylaxis. So by using CRDs or component result diagnostics, you can ask the question, who is the real mischief maker? And again, Narmada told you, with venoms, it's important between a local reaction versus a systemic reaction. So it's always, life is one of balance. There are antigens which have low risk for anaphylaxis. For example, the profilins, the pathogens related, whereas there are antigens which are at high risk. And as far as peanut is concerned, we know ARA-H. But what about wheat? Wheat, which is Triacticum aestivum, that's why it's called Tri-A, and there's a component called Tri-A19. That is the 19th fraction of the purified antigen, which is the same as omega-5 gliadin. And a question was asked, can you get a negative skin test and negative in vitro test and still get anaphylaxis? The answer is yes, because omega-5 gliadin is very minuscule in the component of wheat protein. However, in that individual, where that is the epitope which causes IgE production, that little is enough for them to activate it, and it will be lost in the skin prick test because the concentration is very low, not enough to cross-link the mast cells, and same thing with specific IgE. So here is where component result diagnostics is important. So it's Triaticum aestivum fraction number 19, whereas the common urticaria is by Triactivum 4. So it's a different antigen. So different epitopes, different pieces of the puzzle contribute to it. And we already talked about Arachis as far as peanut is concerned. So having finished specific IgE, having talked a little bit about component, let's move on to tryptase. Tryptase is probably the best biomarker we have. And you all know that tryptase, like histamine, is released when the mast cell is activated by IgE or non-IgE mechanisms. But the beauty of tryptase is it's a stable molecule, whereas histamine and leukotrienes are unstable. So they're rapidly metabolized, whereas tryptase is not metabolized. So it's released quickly from the mast cell, peaks in about an hour and a half, and gradually comes to baseline 8 to 10 hours, depending on the degree of decrease. So quantitation of tryptase in serum or plasma, doesn't matter, provides a practical window of time. So it gives the ER physician, where the patient is coming about 45 minutes later, there's no use measuring plasma histamine or urine 24-hour histamine. You don't have collection of 24 hours. So what he or she can do is draw the plasma serum and send it away for serum plasma tryptase. And that is very useful marker, and I'll share it with you. And tryptase can be measured in a good laboratory, and it could be done in Sri Gangaram. If it's, I think Niraj can correct me. I think they do it, or they are planning to do it. Can be done by ELISA or fluorescent assay. Takes about 4-6 hours from the time you get the sample to the lab. And the normal range, just remember, is 1 to 11.4. So we are all told that levels greater than 11.4 is high, and that is consistent with mastocytosis. The answer is not quite. Can you have a mast cell activation disorder where the tryptase is, say, for example, 9.2 milligrams? nanograms per ml, not 11.4? The answer is yes. How? There is a formula, is your elevation of your serum tryptase depends on your baseline. For example, if there is somebody who has a baseline tryptase of 4, and that is after the anaphylaxis is gone, 2 weeks later you can measure it, and then during the attack it was 9.2, one is likely to say, well, 9.2 is less than 11.4, so it's not mastocytosis, there's no anaphylaxis. But you got to go to 4 multiplied by 1.2, it's 4.8, add 2 nanograms, that comes to 6.8, so that is still high for that person. So that means it is compatible with mast cell activation or anaphylaxis. So one static tryptase reading less than 11.4 does not exclude anaphylaxis. If it's 20 or 25, the chances are very high, but that's very important. But on the other hand, it could be 20 or 25, and it may still not be anaphylaxis because there is a condition called hereditary alpha tryptosemia. So very quickly, let me explain that. That is a variant of a mastocytosis. We have 2 genes, tryptase A and tryptase B. A codes for both alpha and beta tryptase, and the TSA-B2 codes only for beta tryptase. So if you look at it, we get 2 genes from dad, 2 genes from mom. So we all have A and B, A and B. So we can have BAA, BB genotype, or we could be A, and if the mother is only a B maker, so you got a B and then you got 2 Bs because that's what the second gene does, or you can get all 4 are beta chains. What this gene is a copy number variation. If there's extra copies of these, not 2 from mom, 2 from dad, if there are 4 mutations or duplications of the gene, you may have a lot of these genes, they code for a lot of proteins, so the serum tryptase is high. Some of them have features which are different. They have IBS-like features, skin flushing, hives, etc. Others may be asymptomatic. So hereditary alpha tryptosemia can occur as a specific entity, or it can coexist with mastocytosis because they're all hematopoietic neoplasms of mast cell lineage. So the point I want to make is a normal tryptase does not exclude anaphylaxis unless you got the baseline and you calculate it. And an elevated tryptase is not equal to anaphylaxis unless you make sure there is no hereditary alpha tryptosemia. But the beauty is, in hereditary alpha tryptosemia, during an anaphylaxis or outside it's always very high. Whereas somebody who had an anaphylaxis, the tryptase level comes back to normal. That's an episodic degranulation. This is a constant leakage. So I think it's very important to look at that in future. To make the long story short, elevated tryptase is useful in anaphylaxis, is useful in cutaneous mastocytosis, and the new entity called mast cell activation syndrome, where you have a variety of features of mast cell activation, but the tryptase must be elevated. If not, it's a simple allergic reaction. And then you have the genetic mutations. And mind you, whenever the tryptase is very high, it's very important to consult with the hematologist and make sure you're not dealing with the neoplasm of the myeloid series, because basophils come from that as well. So the last test is basophil activation test, which I think I'm reaching my time limit. It's a very, very important test. Unfortunately, it's not yet standardized across the world. Different labs do different, so it's a little tricky to handle basophils because they don't live long. So you got to get fresh blood and you got to work at it very fast. However, the basophil is a cousin of the mast cell. They both have IgE receptors, high affinity, and they both bind to IgE. So you're not only measuring IgE, it's almost like the skin test in vitro. And the IgE is able to induce cellular activation and degranulation of the basophil. It is great for venom studies, which Narmada talked about. It's going to be wonderful when we get purified drug molecules, which is still in works. It's already finding value in Europe for food and respiratory allergies, though in the USA it's lagging behind, and it should be developed in India because it will be very useful. When people can't travel, they can send their serum and one can study it. So what the test is very simple. Basophils have 2 important molecules. One is called CD63, which is located on the histamine containing granules, and then CD203, which is on the basophil membrane. When the cell is resting, you don't have the release of the CD63 to the membrane. But if there is an antigen, activates IgE, activates the mast cell, the CD63 is translocated from the cytosol to the membrane, and the CD203 is upregulated. So what it is the cell which was not decorated is now decorated with two molecules, and there are antibodies available to these molecules, and you can sort out the basophil. You can make sure it's basophil and not contaminating cells, and you can see the pink zone is the CD63 mobilization after an allergen, and if you don't throw an allergen, you get the yellow peak. So if you exclude the yellow peak, 77% of the basophils are activated, and this is a very good test. What it needs is standardization. So what I have done is talk to you a little bit about specific IgE testing in vitro. We talked about venoms and alpha-gal. Then component result diagnostics has opened up the entity of wheat-dependent exercise-induced anaphylaxis, which was alluded beautifully by Dr. Qureshi. And there, skin prick test for wheat may be negative. The specific IgE for crude wheat extract may be negative. So you got to screen them with triatom A19 fraction, which is omega-5 gliadin. And USA available. The order WDEIA panel, they will check for wheat as well as the tri-A19 straight away, so you don't miss the diagnosis. I do want to end by saying tryptase is the most useful biomarker. That's the only test which tells you there is explosive mast cell activation, but it does not give you the cause. The cause still needs tests like basophil activation test, a good history, a good component result diagnostics, and intelligent specific IgE. So what I have done is hopefully giving you a quick tour de force on the testing. And I want to thank you all for being patient and listening to me.
Thank you, Dr. Murali. That was actually pretty educating. There are certain questions. Would you want to answer the question of IgG-mediated drug allergy?
Yeah, I think Niraj asked a question, can IgG cause anaphylaxis? So historically, this was all came out of people using rabbits as a model. Rabbits make both IgE and IgG. The IgG of rabbit can bind to IgG4 receptors on the mast cells and activate mast cells. Whereas the human IgG subclass 1, 2, and 3 will bind to mast cell IgE receptors, but they don't send a signal through the proton tyrosine kinase, and they don't degranulate. So in the humans, monomeric IgG will not activate mast cells or basophils. But then how can you get a drug allergy with IgG? Let us say you have a drug and you make a lot of IgG to the drug. The drug acts as an antigen. The IgG acts as an antibody. You get an immune complex, and that will activate complement. And then C3a, C4, and C5a will bind to what's called anaphylatoxin receptor on the mast cell and basophil. And that's the CD88, which is a nice number to remember, and cause activation. So IgG does not directly degranulate, but using its cousin, the effector pathway of complement, it can activate. Then there are other drugs which don't have to go through IgE, don't have to go through complement receptors. They can activate through what are called neural peptides. Like, for example, morphine, codeine, and D-tuberculari can activate through the substance P receptor. And now we have voltage gated channel receptors. And also MRGPRX2, which vancomycin was described, some of the melatonins and phospholipases can bind and activate that receptor. So you can get anaphylaxis without IgE sensitization. So I tried to answer Querishi's very important question.
Yes, that was really good. I guess other questions are more or less answered. We have Dr. Vedantan here. Would he want to comment on the topic? Has he left?
PK, you're muted. We want to hear your voice. You're muted, PK. PK is muted.
First of all, I am so happy Dr. Murali is here to address us. his brain from head to toe. And what he has done, he has presented to us in 15 minutes a very complicated subject, which he has made so simple, even a medical student can follow. So it has been a fantastic presentation. I have only two questions for you. One question and one comment, Dr. Murali. What is this alpha tryptase? I always thought it is a measure of the mast cell mass, the load. The beta tryptase indicated mast cell activation. Could you please comment on that?
So the older literature added what is called immature tryptase and mature tryptase. The immature tryptase was situated inside the mast cells, and that was called alpha tryptase. And then the beta tryptase is the mature tryptase, which is released from the mast cell on mast cell activation. So in the good old days, they used to measure beta tryptase, total tryptase, because they could not measure alpha. So they can measure beta, they can measure total tryptase, and then take total minus beta, and then tell you alpha tryptase is high, which means the mast cell is loaded with tryptase making genes. So that's how it was. Now, we don't need alpha and beta tryptase. Those assays are not reliable, and only a couple of people have the antibodies. So all you can do is measure total tryptase. The total tryptase is high, and then 2-3 weeks later, it's still very high. It's not ongoing anaphylaxis. Then you probe for mastocytosis or hereditary alpha tryptosemia. If the tryptase was high, when the patient had a shock like syndrome, and then 2 weeks later it's down to normal, then it's anaphylaxis. So this assay is much easier. The total tryptase assay is automated. It doesn't cost much money. It's very fast. It's like getting serum sodium potassium chloride. It's an automated machine. And Thermo Fisher have done a great job in marketing it. They are in India. So when I spoke to one of the representatives, they are very keen on collaborating with allergists there to get this going.
One more, thank you very much. On BAT, this is several years ago. I took samples, several hundreds of samples from chronic urticaria patients to National Jewish. So we were doing a study, and then the whole, to keep it short, the result of the study was the CD203 uptake became a commercial test for the evaluation of CIU. So the thing is, what we found during that investigation was the higher uptake of CD203 seemed to correlate with the autologous serum skin test, which we had done in India. Can you please comment on that? Because that is a sort of a controversial test, depending upon whom you speak to. Can you please comment?
Okay. So the autologous skin test was what Malcolm Greaves did for chronic urticaria, saying that if you draw the serum from the patient and then you inject it, the serum contains antibody to the high affinity Fc epsilon receptor, activates the receptor to cause urticaria. But, actually, Philip Ashkenazi was at University of UPenn, and Philip Ashkenazi was the very first one, followed by Larry Lichtenstein and John Hopkins, when I was a fellow in the late 70s, to show that if you look at patients with urticaria, their basophils seem empty. They seem to be depleted. So they actually said, you can look at basophil quantitation, look at what's called light density basophils. That means their mast cells are being activated. That is correlates with anaphylaxis. The problem is those are very hard to do. What is light density? Who stains it? How many cells do you count? Is the sample good? So all that is led is that mast cells and basophils participate in anaphylaxis, and basophils being circulating, you can get them out of the blood and you can study them. But the beauty is you don't need the patient's basophils because they won't react. All you need is the serum. Let's say I have anaphylaxis to penicillin. Exactly. You get my serum, get indicator basophils. I can draw blood from, say, PK, separate his basophils in 20 minutes. I don't even have to separate it. There are techniques now you can lyse the cells. Add the patient's serum. I may have IgE to penicillin. And then you add penicillin or a buffer. And then you do flow cytometry looking for CD63 mobilization and CD203 upregulation. The reason you use both is upregulation is hard. If you start with 70 and goes to 75, is that right? But if 63 starts at 2 and goes to 70, hey, that's great. So use each as a cross check. So they made observations. The observations led to better optimization.
Thank you very much. Thank you so much.
The
Thank
history
you,
has
Thank you,
Philip
Dr.
Ashkenazi, the Johnson, they all made observations, but it took 10, 15 years to become a laboratory test. Sorry.
Thank you, Dr. Murli, and thank you, Dr. Vedantan, for your wisdom. And there is so much to learn that I understand from the today's talks. Thank you, Dr. Murli, for being here. You can stop sharing your screen. So from these talks, it's very evident that whatever lab data that we have, they're not enough to tell us about the, investigations. We need beyond lab testing. And that's when the skin prick testing and the drug provocation testing comes into the picture. For discussing the same, I'll invite Dr. Indranil Haldar. He's the pulmonologist and immunologist. And sir, your 15 minutes start now.
So, am I audible right now?
Yes, you are, and your slides are visible.
Thank you, Neeraj, and thanks to all the learned faculties here. In fact, I am also learning a lot from here. And what I'm going to do in the next 15 minutes or so is to give an idea about the skin prick testing, drug provocation testing in anaphylaxis, how we can work on it. And to do this, I have just presented a case, a 10 years boy who attended a pediatric outpatient department with chronic urticaria. So there was no other systemic involvement and was managed with antihistaminics. Again, a history which he gave was a 6 months back with 2 hours of ibuprofen. When he took it because of the high fever, he had an exacerbation of the urticaria. Now, at this time, the child attended the emergency of a department with a history that within 10 minutes of taking some analgesic, because he was also having fever, he developed an immediate generalized urticaria, angioedema, and presented with severe anaphylaxis with the chronology of stridor, wheezing, diarrhea. Patient was managed, but now it's time to find out what was the cause and how this could be found out is on topic. So as discussed, it may be this hypersensitivity reaction may be non-immunological, but what we are really interested in the Ig-mediated allergic reaction, which is the form of immediate anaphylactic shock, which includes this urticaria, angioedema, and or bronchospasm. There are also non-immediate allergic reactions like the urticaria and the maculopapular eruptions, some of them very severe like the toxic epidermal necrosis or the Stephen-Johnson syndrome or drug reaction with eosinophilia and systemic syndrome. But we are really interested in the Ig-mediated allergic reactions here. And that is what to differentiate the type, that is the Ig-mediated, the immediate, which is the type 1, where the allergens bind to the Ig antibodies on the mast cell and basophils. With the release of vasoactive mediators, the importance of the histamines and the leukotrienes. And this is the chronology, say urticaria, papular erythema, but ultimately developing into the severe most form of bronchospasm and anaphylaxis. So as discussed by our previous speakers, what is important for a complete drug allergy workup is a detailed clinical history, and it has been repeatedly told that it is the history, and then the physical examination. But this may be followed by one or more of the tests, which we think of the skin prick test, other laboratory tests, and maybe drug provocation test as may be relevant. So the history which has been highlighted, when available, a detailed history of the drug reaction significantly simplifies the risk stratification and management, the dose, the route, the coincident infections, the co-administrated related reaction to some same drug prior, because as seen by my previous speaker, where Dr. Qureshi has told how the history taking is very important to find out that the latex was one of the important component in the allergy. the reactions, the latency, onset, duration are all important in the history. And then comes the testing, the skin testing, which may help the skin testing, the patch or delayed testing, the drug challenge, or some of the genetic testing that may be relevant. The skin testing can help identify the culprit that is essential for appropriate drug avoidance. It can also identify medications safe for drug challenge or delabeling a drug allergy, which has been discussed. It may be the prick or the intradermal or the patch and delayed intradermal test. There are no commercial available drug-specific laboratory tests in that way, and drug-specific IgE testing may not be helpful in most of the cases. The skin testing, it is an immediate skin testing which is used for the possible IgE-mediated reaction, but we should know that there is no role in Stephen-Johnson or toxic epidermal necrosis, acute interstitial nephrosis, or nephritis or hemolytic anemia. We have to ask for concomitant medication that can interfere with the skin testing and avoid prior to that for the skin testing. For examples, the long-acting antihistaminics to be stopped for more than 5 days, cetirizine, fexofenadil. The short-acting, at least say more than 48 hours. The histamine H2 receptor antagonist, at least 24 hours. We may ask the patient to hold or decrease the dose of beta blocker for a high-risk patient. In fact, some other drugs like the tricyclic antidepressant and antipsychotics may also interfere with the result. You also should know that a following negative skin test result, the absence of allergy should be confirmed with a drug challenge when possible, which I will discuss. So it has been discussed, and it may be not the right forum to tell how the test has been done, but again, skin prick test, which is measured in 15 minutes with a histamine control and a saline control, positive for more than 3 millimeter, a flare more than 5. If negative, we can move on for an intradermal test in duplicate, which to be measured in 20 minutes. And the final step may be, if negative, with a drug challenge when possible, which is to be followed by observations. So just to highlight what is about the skin testing for the drug-specific IgE, a variety of medication can be used to perform the skin or the intradermal test, prick test or the intradermal test for the purpose of determining if the drug interacts with the drug-specific IgE bound to the cutaneous muscle. In fact, this type of testing is also only used to evaluate suspected type 1 allergic reactions, and the positive will to be seen in 15 to 20 minutes. As a clinician, we must first ascertain that the medication does not cause direct muscle degranulation, which are seen in some of the medications like opioids, quinolones, and vancomycin. Medication that activates muscle directly cannot be studied with this type of skin testing. Drug solution used for testing should not be non-specifically irritating to the skin, and it is only non-irritating concentration with the variety of medication that can be determined. So a positive result is indicative of allergy, providing non-irritant concentration of the drug is used, but a negative result does not exclude allergy because the patient may be allergic to metabolites of the medication or metabolites protein complex and are generally not available in skin prick testing. So skin prick testing may be falsely negative if performed too soon after an anaphylactic reaction, and that is why we have to wait for at least a few weeks after an anaphylaxis to do the skin test. At least 4 weeks is what is recommended, should be allowed between a severe reaction and the skin testing to suspect a drug sensitivity. If, however, a skin test is performed in this period, but a positive result are still valid. False negative result can also occur in patients who are taking medication, but blunt immediate skin response, such as H1 and H2 antihistaminic and tricyclic antidepressant, may decrease the result. Now coming to the other test, that is the drug challenge. It is a procedure whereby the drug is administered to determine tolerance, which may be referred to as the test dose or the drug provocation test. When a drug challenge is not preceded by the skin testing, it is called the direct challenge, which I'll come where to do a direct challenge. It is only indicated for low risk patients who are likely to be allergic or after negative skin testing. That is normal, the protocol that is followed. Performed under medical surveillance. It is not to be done for life-threatening reactions like the Stephen-Johnson's or the toxic epidermal necrosis. Completing a test dose or direct challenge without an adverse reaction indicates that there is no immediate drug allergy, but this does not rule out the possibilities of a delayed benign rash, which may occur days after the challenge or with neck doses. The protocol may be a direct challenge, that is when it is done without prior skin testing, where a full dose is given and observed, or a graded challenge where it is increased from 10 to 25% observed for 30 minutes, then advise the remainder of the dose over 60 minutes to 2 hours. So just to define, it is a controlled administration of a drug to diagnose drug hypersensitivity, and maybe one of the last steps for accurately recognition of drug hypersensitive reactions. We require a trained personnel and equipment for emergency resuscitation. Definitely a consent. The agent should be there. Routes may be oral, parenteral, cutaneous. Starting dose depend upon the severity, and interval of 30 to 90 minutes may be given. So it has a few advantages. There is confirmation or exclusion of diagnosis of drug hypersensitivity, less use of more expensive alternative, less use of broad spectrum antibiotic at decreased risk of antibiotic resistance, may reduce the cost of drug allergy. It is generally safe, has a good safety profile, is acceptable, avoids unnecessary desensitizations, and provision of safe alternatives can be found. But the protocol may be based on patient, has the disadvantage that it should be based on patients. Patients report about the reaction suffering, false positive and false negative result may occur. Co-factors may be there. Potential risk of resensitization is also there. Although a very well standardized, many contraindications are there. Lack of standardized protocol is still there, and subjective symptoms may be difficult to interpret. So the diagnostic algorithm may be there. When there's a clinical history index reaction, for example, if it is occurring in less than, that is immediate reaction is there, we should find out in vivo test if it is available, or negative, we can go for a skin test. If it is negative or contraindicated, then we can go for the drug provocation test. Only in non-immediate reactions, where there is mild eruptions, then we can move on to direct drug provocation test. So there are some contraindications or not preferred, which may be patient-related. For example, in uncontrolled asthma, uncontrolled underlying chronic disease, pregnancy, patients cannot stop their beta blocker. If there is an underlying heart disease, a contraindication for the use of adrenaline if any untoward reaction happens. Or it may be due to index drug hypersensitivity where there is vasculitic syndrome, or as I told, if there is a Stephen-Johnson or toxic epidermal necrosis, if there is acute generalized eczematous pustules, or drug-induced autoimmune disease, or DRAS syndrome, or involvement of specific organ system, or if there is a severe anaphylaxis, or unlikely to be needed and several structure-related alternative exists, then it is useless to go for the DPTs. So whether to go for a direct challenge or after a skin test, it has been discussed that risk stratification is important. Skin testing is of value for patients with a history of drug-induced anaphylaxis or a recent reaction suspected to be of IG mediated. So direct test, again, I'm repeating, is offered for low-risk patient with benign non-anaphylactic-like reactions. And definitely a shared decision-making in diagnosis and management is there. So the challenge protocol, the place of the challenge and degree of caution exercise depends upon the likelihood that the patient may be allergic and the patient's medical stability and the clinical experiences and the level of comfort with the procedures. Pre-medications, that is with histamine, glucocorticoids, has to be taken history. Beta blocker history has to be taken for control of hypertension, should be withheld at least for 24 hours. Patients with asthma severe COPD, in fact, not that in pediatric or other pulmonary diseases, should have their pulmonary symptom optimally controlled prior to doing this procedure. So coming to the immediate reactions, if the previous reactions occur less than 1 hour after drug administration, and there is a concern about the possibility of IgE-dependent reaction, the challenge should be performed by an allergy expert, and the setting equipment should be ready to treat the anaphylaxis. The starting challenge dose depend upon the severity of the past reaction, and in general, with the symptom may be caused by IgE immediate. A lower dose may be used. In fact, the oral dose is what is preferred when possible, and then tenfold increasing dose after 30 to 60 minutes until a full therapeutic dose is achieved is what is done. So interpretation is also very important, though it may be looking very simple in theory. Graded challenge can require experience to interpret. Some of the patient may develop non-specific and subjective symptoms during the procedure, which may mimic the symptoms of a true allergy, and that an experienced allergologist may determine and find it out. These may be due to anxiety related, and spending time with the patient explaining the safety of the challenge procedure in advance may help to reduce the incidence of this non-specific reaction. So if the patient develop convincing signs and symptoms consistent with an immediate reaction during or shortly after the graded challenge, no further drugs should be given and symptoms should be treated appropriately, and the patient should be diagnosed with immediate allergy. But if only subjective symptoms are reported, the patient can often be reassured and the challenge may be continued. Patients with a negative challenge, there is still the patient may develop delayed reaction to the drug in question, but this may not be that very serious. What is important is the negative predictive value of the challenge procedure, that if the patient tolerates a drug challenge, it is highly unlikely, but it is not impossible that the drug will cause symptom if taken in the future. So if the reaction was not life-threatening, the drug can be given in normal manner in the future. However, for patients with recent and severe anaphylactic, even if the skin testing and if the challenge is negative, it is prudent to give the causative agent only under a medical supervision. So I should conclude that skin tests are the best standard for identifying the IgE-mediated drug sensitivity, and the drug provocation test is reserved for cases where skin test and history are inconclusive, serving as a confirmatory test. So both the tests, the skin test and the drug provocation, are complementary. Skin test identifies the trigger. The drug provocation test confirms the safety of the alternatives. What is important is prioritizing timing, patient-specific risk assessment, and rigorous safety protocol to minimize the recurrence of anaphylaxis. So thank you. And now we can
Thank you, Dr. Haldar. That was really crisp. My question to you is, in India, it is seen as imperative to go for an intradermal test before giving any antibiotic, irrespective of the, antibiotic that we are using. We know that many of them do not cause IgE-mediated reaction. And if you don't do it, it is taken as, not substandard way of correction. Do you agree with that kind of protocol that we are following as a preventive measure, or would you advise certain changes there?
So definitely this has been done. In fact, if you see, when we are still medical students, say 30, 35 years back, even giving any antibiotic, be it penicillin, cephalosporin, we used to do an intradermal test, and that the sister used to do it and see an immediate way. So what this does is to detect immediate IgE-mediated reaction or the anaphylaxis. So except that, other manifestations or other reactions cannot be determined by that. So in fact, it may be justified in some of the antibiotics, but not in general to all of them. So it is only detecting the immediate IgE mediated, not all type of anaphylaxis. And it may be justified in some of the cases, in some of the antibiotics, but it cannot be generalized or cannot be tested as a baseline or something sacrosanctal that, yes, no reaction, that means it is safe to be given.
Yes. We can take Dr. Murli's opinion on this. Do you still have a practice of using an intradermal test for antibiotics like quinolones, vancomycin?
We don't. The reason is you get so many non-specific reactions, it actually acts as a hurdle. Let us say you do an intradermal and you get a wheal and a flare. Is that an irritant reaction? Is that a toxic reaction? And so what happens is then they say, oh yeah, there is a possible allergy, we won't give that and go for another drug. So I think the intradermal reactions for drug has a lot of false positives, irritant reactions. The split test, if for certain drugs up to certain well worked out concentrations, I fully agree it's a very valid tool. So at least we don't do intradermals for drugs anymore.
Fair
For
enough.
quinolones, the quinolones we should not do because again, quinolone itself will cause immediate reactions. So for quinolones, we should never do it at least.
But then if it is negative, it gives you a good negative predictive value. Would you say that?
By and large, yes. But then you see, it only gives you a negative predictive value for IgE. But if the drug were to activate the complement cascade or the kinin pathway, and then you can get a vascular collapse. So I think the prudent thing is give the drug and wait and watch.
Can I please comment
Yes,
just
please.
quickly? Before going for these intradermal tests for every other drug, the question is, do we have recommended non-irritating concentrations of these drugs available? I mean, not every drug has been these concentration recommended non-irritated concentration have been validated. It's only in case of some drugs where it has in fact only some beta lactams it has been validated. Otherwise, some concentrations are available, but they have not been validated. One point is that. The other point is that of course, even this doing this intradermal testing, when it comes negative, it has at least ruled out the Ig immediate reaction. But with all the costs, risks and costs it bears on the life of the patient. So that is one more point.
Can I comment?
Dr. Kureshi, what do you think that what the sister does is just take about a 0.1 ml something like that from the vial itself, for example, not beta lactamase, and just do it intradermal test. Are those to be thought to be non-irritating or at least can be used?
Sir, actually, there are 2-3 mistakes what happen while doing intradermal tests in setups like ours. One is the wrong technique is used. Most of the injections go subcutaneous. Then wrong concentrations are used, and wrong needles are used. And then there's a wrong marking and wrong reading. What has to be done ideally is that after using the right concentration of the drug, you have to do it intradermally. Raise a bleb, then the bleb, the wheal that gets raised, the circumference of that has to be marked. And wait for 15 minutes and see if that bleb gets extended more than 5 mm beyond that circumference. Then only in that case that test can be read as being positive. Of course, in those cases where intradermal testing is recommended. And one more point I forgot to add is that there are some classes of drugs where intradermal testing has some value. And apart from these beta lactams, the class of drugs which has this value is the general anesthetic agents. General anesthetic agents you cannot do a challenge with them. Obviously, in that case, this has some value, and there are protocols for the local anesthesia drugs as well, where we start with a skin prick testing, then intradermal testing, and later on a full-fledged challenge with the subcutaneous route.
Can I make a comment?
Yes.
First of all, let me congratulate Dr. Indranil, talking about a very difficult subject. Even allergists are hesitant to talk about drug allergy. So this topic is a bag of worms for several reasons. First of all, we do not know mechanisms in most of the drugs. Second, what drug that you inject is not the same what the body will react, because a lot of these drugs are low molecular weight, they are unstable, they need haptenization. So for the body to react, for that particular drug to be antigenic, it has to go and hook on to a protein. And this haptenized protein is what the body will react to, which is very different from what you are injecting. So skin testing is reliable only for very few drugs as far as we know. Penicillin, muscle relaxants like flexitinoline, insulin, and maybe another one or two of them. So most of the drugs, you don't know what you're doing when you do skin testing, whether you do non-irritating concentration or irritating concentration. So non-irritating concentration is definitely a progress. But if you are positive on a non-irritating concentration, it only means it is not an irritant. It does not mean it's IgE mediated. So let us not confuse that positive non-irritating, positive reaction to a non-irritating is IgE mediated. It only means it is a better way of testing. We still do not know the mechanism. So as far as drug allergy goes, the standard right now is graded oral challenge. And the advantage with that is it is useful irrespective of mechanism, whether it's immunological, non-immunological, IgE mediated, non-IgE mediated. So that is what we have right now. Things may get better later. So we have to be careful when we interpret skin testing. Thank you.
Thank you. That was really educative. And we know there are so many lacunas and much more knowledge is required before we start implementing. There is one last question for Dr. Narmada regarding the venom immunotherapy that is presently available in India. Could you please elaborate, Dr. Narmada? Are you on mute, Dr. Narmada? Hello?
Maybe she's gone.
Sorry, no, I'm here, sir. I'm here, sir. Thank you. Yeah, sorry. Yeah, tell me, Dr. Shalini. Sorry.
So there's a question regarding the availability of venom immunotherapies in India.
Yeah, that is that now Alcure is giving the allergens for the venom immunotherapy. Dr. Soibal, and I also spoke with Dr. Sitesh Roy, who's doing on that. He does on a bee venom there. So there are products they are giving, and the skin testing also. The Credisol also has all the insect venoms. But whether the standardized, the major allergen component, all that, it is a matter of question. We need to do more about that.
As far as I
Have the
know,
whole body extracts.
I do not think standardized insect venoms are available in India.
Yes.
Because there's only, even in the US, there's only one company that makes it, which is Jubilant Holocystria. So many people have stopped doing it, even in the US. So
but
you have to be careful what you
sir,
test
in the UK, sir, they have a very standardized allergen where even the dilutions are given.
Even we talked to these guys once, they said that this is a whole body extract.
No, fair enough. So in our country, a year ago, we were talking about non-standardized extracts of mite, and now we have them as well. So allergy field under the leadership of, senior doctors like Dr. Vedantan and then spearheaded by Dr. Neeraj Gupta is definitely growing leaps and bounds, and I'm sure we'll get something more in the coming years.
Just like that, it is the same, the sublingual immunotherapy. Now we have got the same Macarex group. Now, so the same company only is doing the allergens in London. So if it is possible, we may be getting it.
Definitely. So with that note, I would ask Dr. Neeraj to conclude the session. We really had a very informative session today. All the speakers were very crisp, stuck to their time, and the information was loud and clear. And with Dr. Vedantan's and Dr. Murli's inputs, there was definitely much more knowledge that was imparted today. Dr. Neeraj, sir, over to you.
Thank you, Dr. Shalini. Actually, it was really a very wonderful session. And when I planned or designed Anaphylaxis webinar series for 3 days for 120 minutes each, at that time, there was a question which was raised that anaphylaxis, why more than 20 minutes? Means like it can be finished in 20 minutes. And now I'm realizing that 3 webinar series is actually less, or probably 7 hours or less. We require more time. And I was just looking at the schedule for the third series or the third webinar, which is even more, I will say, you can say like more interrogating, more questions will be there. So I'm really very happy. And the level of questions and the level of moderation which you have done with this type of difficult webinar. Thank you very much for doing that. Thank you, Murli sir. Thank you, Vedantan sir. for your inputs. Thank you, Dr. Indranil. Thank you, Dr. Taha, Dr. Namrata, Dr. Soumya. Everybody, so much thank you. Thank you. Have a good night. Thank you.
Good night.
Thank you.
Good night, everyone.
Night.